Welcome to Can I Butt In, the Bowel Research UK podcast, where we welcome bowel cancer and bowel disease patients, researchers, healthcare professionals and carers to butt in and share their experiences. We're picking a topic every episode and getting to the bottom of it. I'm your host, Alexandra Rose. I'm the Patient and Public Involvement Manager at Bowel Research UK, and as a patient myself, I'm excited to bring more patient and researcher voices into the spotlight. This time we're taking a look at a surgery that you might not have heard about before called pelvic exenteration, and we're going to be looking at how this can affect a person's quality of life and also what research is being done around this type of surgery. So I'm joined by Sharon Applin, who has had this surgery herself, and also Charlie West, who is a colorectal research fellow at the University of Southampton. Welcome both of you to the podcast.
Good morning, Sam.
Good morning, thanks very much.
Thanks both for coming on. So should we start with you, Sharon? Could you please tell us a bit about your story, what you were diagnosed with and how that sort of came about?
Yeah, absolutely. In 2020, I was diagnosed with a skin cancer, which is called a squamous cell cancer. It was on the left side of my anus, but at the very beginning, I was informed that they thought it was a fissure tear. So I was being treated for this and also maybe piles because they didn't quite know what was happening within that region. So I actually went to see a specialist at Paul Hospital who took one look at me and basically said, that is not a tear. There is something more going on there. And he hadn't seen anything like this before. So he was a little bit concerned. And then I was promptly booked in to have a biopsy taken. And the biopsy then showed that obviously this was cancer that I had. So after the biopsy and being told it was cancer, I had no symptoms of bleeding, diarrhea, being uncomfortable to sit or anything like that, which again threw them off the scent that this probably was cancer until the biopsy was done. So the plan then going forward actually then meant that I had to look at treatment and how they were going to treat this problem. After organising a plan, which they were going to give me, the plan was then that I would have 5 weeks of intensive therapy. The therapy was chemotherapy at home by tablet form, and then radiotherapy, which was done at Paul Hospital every day of the week for 5 weeks. This was carried on right up until December 2020. Then it was January 2021, I was given the all clear, and I was given the possibility that it could come back. It might not come back, but they would keep checking on me. I was clear for 1 year, and then the skin cancer came back on the other side of my bottom. So not in the same place, but it had found another place to come to, and that was the other side of my bottom. So in 2022, in January, I went back to my doctor who was been looking after me at Paul Hospital. The cancer was quite advanced at this point, and she informed me that the surgery couldn't be done there, so I would have to go and see another consultant. I then went to Salisbury Hospital and saw a consultant there. And unfortunately, again, after taking biopsies and looking at from scans, what was there, I was sent to Southampton Hospital, where I had my surgery. The surgery was carried out there, which took some time to get the surgeons all together. I had a 15-hour surgery. And once coming round from that surgery, obviously I had 2 stoma bags. So living the life with 2 stoma bags and waking up knowing I was going to have them, but to actually then get your head round where you are, how your life's going to be, the changes you're going to have to make was quite difficult, very difficult, very emotional, very hard to get your head round. And it still is now, because it's only September since I came out of hospital last year. So it's still young and it's still raw, really, in the sense that everyday life is quite a challenge. It has changed my life completely. I can't just walk out the front door anymore and think about just going to the shop like normal people do. I have to think, are my bags done? Am I safe to go out today? How long it's going to take me? Take my kit with me just in case I have a hiccup. Take extra clothing with me in case there's a hiccup. So yeah, it's very difficult from day to day.
Yeah, gosh, I can't even imagine. And that's such a big operation, isn't it? 15 hours. I mean, is that like one of the longest operations a person can have, I wonder? I mean, it sounds very difficult to recover from. Must have been very painful.
Yeah, the team are very good regarding your threshold of pain. You know, they're there every day. How are you controlling your pain today? You know, is what we've given you working? So, you know, when you're in hospital, that's fine because you can get that pain sorted out quite quickly. When you come home, you've got to learn all over again. You know, having 2 bags. When you're in hospital, you push a button and a nurse comes and changes your bag for you. When you get home, it's like, oh, husband's at work. I've got no help. I'm going to have to wait for him to come home to help me with my bag. And, you know, so you have to think outside your normal zone that you would be in every day of the week. You know, you can't just think, let's go shopping, because you've got to think ahead, where am I going to park, because I can't walk the distance that you normally probably would walk if you're going shopping. I have to think about exactly where I'm going to be. I can't just go mentally, because once I get there, I go into a panic mode and think, where, you know, should I have looked at where I'm parking first, and should I have done my sort of like survey of where I'm going for the day, which I do have to. Yeah, it is. And where you say, Sam, about it being one of the longest operations, that operation was actually cut down. Initially, I was told it could be over 2 days.
Oh, wow.
But luckily enough, because of the team that was put together, which was a team of 5, we started at 7:30 on the Friday morning. And from that, the operation was able to then continue and go through the night. And they obviously operated on me right the way through, taking it in turns, I suppose, with the surgeons who could then have a rest and come in. But yeah, I know from my notes and what have you, my plastic surgeon was 4 hours of actually sewing me back up and putting the sleeve that I had to have removed for the skin from my stomach to form the new sleeve to where my bottom used to be and where my vagina used to be. That was 4 hours, 4.5 hours actually, of sewing me back up and taking the muscle from my tummy to put in the empty pelvic where everything was removed from. So yeah, as you say, it's one of those operations I would imagine is probably one of the longest, but not being medical, I don't know. Charlie might know better than me, but yeah, I would imagine it could be one of the longest ops there is.
And what is actually removed for people who aren't familiar with pelvic exenteration? What is it that they take out?
Okay, I can imagine it might be different for some people to others. I'm not quite sure on that one, but my personal experience that I had taken out was I had my bowel, my vagina, my clitoris, my uterus, everything that's in the pelvic was actually physically removed, including part of my pelvic bone and also my pubic bone. Part of that was removed because the cancer was millimeters away from that area, and to make sure the disease hadn't started feeding into there, part of that was also taken. Nerve ends were removed as well. So that's why I have the difficulty now with walking and numbness in the tops of my legs. Yeah, so a lot completely empty, everything completely gone. So I don't even have a belly button anymore because the skin they use to sew you back up is taken from that area.
Oh, so it's just flat.
Yes. So I
Right.
have
Oh.
that tummy. Yes, there is no belly button. Yeah. So there is you have to have a lighter side of this surgery. I learned to laugh a lot and make funny comments about, how I was now. I used to say I'm not a female anymore, but I'm a Barbie doll, because I don't have any of the bits a lady has anymore, but I do have a Barbie.
Yeah, I think having a sense of humour around cancer is really important. It certainly helped me to get through my experiences as well. So shall I bring Charlie in at this point then, because you're doing some research into pelvic exenteration? Could you give us an overview of what you're researching?
Yeah, so I think as Sharon's already said, these are really long operations. 15 hours is a really, really long operation, and they can take longer than that sometimes, and sometimes shorter. And as Sharon has said, there's a huge amount of to control a really difficult cancer. You might need to remove a lot of organs in the pelvis and bits of the pelvic bone and skin. And what's really important is that reconstruction aspect. So how you put the body back together again after the surgery, to get people back to as good a quality of life as they can get, because it's huge. I mean, it's life-changing surgery. I don't think anyone really comes through this operation exactly the same as they were, before it. And it takes a long time to get used to. And I'm interested in looking at the reconstruction aspects and how that can reduce complications and try and get the best quality of life for patients after their surgery.
I suppose it must be something quite difficult to research if people are having the operation for various different reasons and different types and locations of cancer, and then being reconstructed in different ways. Yeah, it sounds like there's a lot of variables to contend with.
Yeah, it is difficult, and it is very difficult, and it means that there's quite a lot of variation in what surgeons do in terms of reconstruction. And you're absolutely right, these pelvic exenteration might be done for tumours arising from the skin, like Sharon's had, or from the rectum, the bowel, or maybe the bladder or the reproductive organs, or even sometimes the connective tissues or the bone as well. And those are all different types of cancer, and it might be done for disease that's already been treated with an operation but has come back again, or it might be done for disease that is quite advanced when it's first diagnosed. And you're absolutely right. It's a difficult group to research because each patient almost has an individual operation designed to specifically for them. And it means that, again, the reconstruction that needs to happen might again have to be specific for that individual patient.
Something that seems like it might be quite common between different patients is this empty pelvis syndrome that you're looking at. Could you tell us a bit about that?
Yeah, so it's not a very well defined problem, but we think that patients that are having this big surgery where they have lots of their pelvic organs removed, they're left with a large space at the bottom of their body where all these organs were in the pelvis. And often, as Sharon mentioned as well, patients have radiotherapy before their surgery or during their surgery, and that can also damage the pelvis, and it can lead to problems with ongoing infections in that area, or it can damage the intestine in that area. So if you want to look at reconstruction and improve, and try and get the best outcomes for patients, trying to address this problem, the empty pelvis syndrome, is an important part of that, and that's the real focus of what I'm looking into.
How's the research going so far?
So it's going really well, actually. So the first part of this is to try and agree a way to measure the impact that the empty pelvis syndrome has on patients. At the moment, there's not really an agreed way of saying this is how bad someone's empty pelvis syndrome problem is. So that's been the real focus to begin with. So I've been using something called consensus methodology, which is where you get people to try and agree on a problem that is difficult to define and to research. And if you can get people to agree, then you can start to produce better quality research and try and find the best techniques to help patients more quickly. Whereas if at the moment people are reporting research in this problem in different ways, so when you try and put research together from different hospitals, it's quite difficult to compare that research to find out exactly which technique is better. So the first part of my PhD has been trying to get an agreement on the empty pelvis syndrome, and we've been doing something called a Delphi study, which we've just finished in the last couple of weeks, actually.
So what are the next steps then, or what do you hope that will come out of this research?
So an important part of the methodology is going about it in a way where you get lots of people's opinions, lots of people agree, and we've been lucky in that I've managed to engage with a group called the Pelvic Collaborative, and that's an international group of hospitals that do this kind of complex surgery from all around the world, and we've had healthcare professionals contributing their opinions from many different countries, which has been really great. But we're very conscious that all these world experts in surgery, they're not experts in actually suffering the consequences of complications after the empty pelvis syndrome. And people like Sharon and that have had this surgery have been really important in getting involved with this, because we've also, in terms of the study, we've treated the patient's opinions on this problem just as much as we've given them the patient opinions just as much importance as we have to the healthcare professionals. So we've got the patients to vote on statements, and we've had meetings with them online. So what we hope we've produced is something that is meaningful for patients and surgeons together. So that I think that gives a more powerful and more meaningful research going forward.
Absolutely, definitely really important to get patients involved in research. I think especially when it is going to affect people in lots of different ways. And Sharon, you've been involved in this research, haven't you, in
Yes.
helping with this?
Yes, I have. It's been quite interesting actually to see what people find more important than others. You know, one person might find one issue very important. I found they gave it a 9, say, and I gave it a 7, and it was quite interesting to look at it overall to see. You know, it's probably like in the morning you get up and say I like tea and toast, and you say, oh, I couldn't eat tea and toast. It's seeing what actual people think is most important in life, you know, which way round they look at different aspects of the surgery. So yeah, it's been really interesting helping Charlie, and hopefully we can carry on doing something like this together.
Yeah.
Because mentally it helps me as well to talk about what's happened, but it also helps to listen to other people's inputs as well.
Yeah, we had some meetings online, didn't we, with patients from across the UK, and it was really nice to, even though none of you had obviously met before, you'd all been through something very similar and had problems, and it was really nice to see just to see the support almost that you were getting in the meeting, and realizing that you're not alone and having these problems.
Yeah, because one of the problems that Charlie's just mentioned is infection, which I've had a couple of times now. Which obviously comes from the fluid buildup in the empty pelvic area. So after that happened back in March, my new skin has actually opened to a very tiny hole, and I now drain from that hole the fluid that builds up in that empty area, and that is continuing to drain all the time. Some days it's more than others, but I've just had my CT scans, MRI and PET scan yesterday. So I'm hoping the results next week, when they look at them at Southampton Hospital at their meeting, will show hopefully the infection has either subsided or is not as bad as it was. But that's only an infection caused by the fluid being in that empty area.
And so how did you come to get involved in being in this research then, Sharon, just for people who might be listening and think, oh, I'd quite like to be involved in research as well?
Yeah, I was in bed one day and this nice young lad came and saw me and said, hello, I'm Charlie West. He said, I would like to ask you a question, and he explained what he wanted to ask me. And at the end of our chat, he asked if I would be interested in doing this, and I said yes, I would. And obviously I signed a consent form to say that I would do these things for him. But also the same thing happened when they came and asked me if I would donate my organs before surgery, and my bone to cancer research, which also happened to me through Charlie's side of the research. So so I signed 2 pieces of paper. One was to help Charlie with the empty syndrome, and the other one was for them to take my stuff away that they took from me, to look into the research even more of what was going on.
Did you have any reservations about saying yes to any of that, or was it an easy decision for you?
No, it was an easy decision, because at that time you think your life is like changed completely and you can't do anything anymore. You're not a person anymore. Do you know what I mean? And to be able to, for somebody to come and say, would you like to help? You think, oh, I am important still. Somebody still wants, to involve me in something. So yeah, I think that's a really good thing. Yeah, it's a mental thing, but it's a good thing. Yeah.
Yeah, it's like not just being seen as a patient, but somebody who's very active, and that helps with identity, I can imagine.
Yeah, absolutely. It's it just makes you feel like you're not at the end of a very horrible thing that's happened to you. You're actually seeing it and carrying it out the other side.
Yeah, and I think if you get involved in research a lot, you almost become a part of the research team, really. And I think that is really, it's nice to I've met with you quite a few times now, haven't I? Either over the telephone or face to face or on meetings, and it's nice to, and I almost see you like one of the research team, which is, and you are really, and having that influence on the research, both with the recovery aspect, but also the more looking at the tumor under a microscope and trying to understand why these things develop, and testing various treatments on it. Who knows where your actual tumor is now? It's probably in some lab somewhere, but someone, I'm sure, is trying to get as much information out of it to help future people, and that wouldn't be possible without your help.
Yeah, I think that side of it is one that you don't get to see, and which would, in one day, maybe somebody will come back to me and say, this is your paper from what we got from you. You don't what will happen, and that would be quite interesting to actually say, or somebody to say to me, this is what we found, this is what we've seen. But Charlie's right, we've all become really good friends, and even my team at Southampton are all in first name terms. I don't call them doctor this or professor this. They are first name terms. And even the nurses, when I go back now, if I don't go to the ward and go and see them all, oh dear, I haven't heard the last of it. So yeah, it's amazing people.
Well, that's wonderful to hear, and a great endorsement for patient and public involvement, I think. Definitely. And just goes to show as well that there's multiple different ways that you can get involved in research. I think that sometimes when people hear the word research, they think about scientists in lab coats in the lab looking at things under microscopes, and that might seem quite inaccessible to people, but actually there's, as you've demonstrated, these different ways to get involved in research as well.
Yeah, absolutely. There's there's lots out there. I'm now working to do some bits with Planet, which is one of the cancer research, the cancer team that do charity work with Southampton Hospital. So that I'm now going to be doing some bits with them as for their stoma people that they have at meetings, and maybe do a small talk on actually what I'm talking about with you today. So yeah, there's and I've met you, Sam, now as well. Over the last 5-6 months, there's Charlie, there's you, and there's Planet. So even though you have this horrendous surgery, there's just so much more out there after surgery.
Absolutely. Well, one of the other things I was going to ask you, Sharon, was if there is anything else that you think that people should be researching about pelvic exenteration, are there any other issues that you think aren't being covered that you'd like somebody to look into?
As a professional side, I can't comment on that because obviously not being medically minded myself. But as a patient, there is one thing that I am hopefully going to be working with Planet to do, and maybe Charlie as well, if we could do something like this, is to write something for patients before the operation so that they know what to expect from a patient's point of view, and not hearing all of the words that a doctor gives you that I came away thinking, what did he mean by that? Or put it in layman terms, I think. And also after surgery, meeting other people that I did in March when I went back in with this leakage that I had. The girl in the bed next to me, who's become a dear friend to me now, Claire, she is so lovely, but she was so confused with what she could do, what she couldn't do, what she could eat, what she couldn't eat. And the two of us sat there and spoke for hours, and we still do now on WhatsApp. And that's another thing I'd like to do, is perhaps do a small pamphlet for people to take away with having just, not medically, just from a patient's point of view of this is what you can expect. Don't lose faith. And, them sort of things, a bit of a reassurance to make people feel a bit more confident about going home. Because when I got home, I thought, I've got nothing to read. I've got nobody to talk to. I didn't know anybody that I could ask questions about. And I think if they could issue that pamphlet for somebody to take home, I think that would be a really good thing that's come out of what my experience would be.
Yeah, I think that would be brilliant. That sounds like something that would be incredibly useful to people. I mean, I'm guessing that you hadn't heard of pelvic exenteration before you'd had it.
No, I hadn't even heard of, well, I had heard of my cancer before, because unfortunately my brother-in-law had exactly the same cancer. He had it of the throat. So I had heard of that, but yeah, absolutely. To be told what I had got and where it was and what it was going to be called once it was done was like, well, I've never heard of this before. Yeah, it was all very, very new to me.
So I think I have just one final question for both of you, which would be, what one takeaway would you like people to know about the experiences of people who've had pelvic exenteration, or for Charlie, one thing that you'd like people to know about the research?
I think the main thing that I before starting my PhD, I hadn't spent a huge amount of time doing clinical research, and I was really interested in doing what I'm doing because I do get to spend more time with patients. So I know the lab-based research is really critical as well, but that was the appeal for me. And it's been amazing to meet people like Sharon, who, and I'm in awe of people like her. She's undergone this huge operation and she's had some complications, and yet still she's wanting to help us, help patients locally through her work with Planets, but also she's engaged with this process that I'm involved in, where we're trying to get agreement with surgeons and patients across the world, and yet she's recovering from this massive operation at the same time. And it motivates me to continue doing what I'm doing, really.
What about you, Sharon? What one takeaway would you want people to have?
To not give up faith. Believe that you can get out at the end of the horrible times, because as much as it's easy for somebody to sit there and say, oh, you'll be fine in a couple of weeks' time, you're not, but you will get there. And just take every day as it comes and conquer that day, and then conquer the next day. Don't try and run before you can walk, and just keep your team together that look after you, because without them, I wouldn't be where I am today. Amazing bunch of people, but don't ever be frightened to ask. I was always frightened to ask at the beginning, and I kept quiet, but I learned over time, open your mouth and ask the question, and somebody will be there to answer it, or somebody will be there to help you. And if they don't know, they'll find somebody that can help you.
Brilliant words of wisdom to end on there. Thank you both so much for taking the time to talk to me.
Thank you, Sam, for your time, and thank you, Charlie.
Thank you both. It's been great. Thank you.
Thank you for listening to Can I Butt In? This podcast was brought to you by Bowel Research UK. Find out more about the charity, our work, and how you can get involved. Visit bowelresearchuk.org, where you can join our People and Research Together network, or PART, read about our research campaigns and fundraising, or make a donation to support the vital work we do. Let's end bowel cancer and bowel disease.